Thank you. It's really a pleasure to be here today. I hope I can hit some of the key points that you just referenced in terms of well-being as well as equity-related issues. So I'm going to just talk briefly today about principally two efforts to give you some perhaps food for thought as you think about objectives and LHI. One from a more local effort to develop a civic well-being index, and then work that we've been doing with the Robert Wood Johnson Foundation on building a culture of health in America, as well as some just concluding thoughts. So one thing I just wanted to start with is a framework and a visual that we developed in collaboration with the Robert Wood Johnson Foundation, as well as my colleague Carol Graham at Brookings. Given that you're focused a little bit on well-being as part of your thinking going forward for HP 2030, thought it'd be useful to kind of articulate how we think about levels of well-being, both in terms of subjective experience as well as what we might call objective conditions of the environment, the community, the civic context, and the ways that we think about this, not just in terms of individual well-being. You'll hear comments, I think, throughout the day about capturing subjective experience, but also as we think about some of those upstream drivers and environments at the community and civic level. Let me just talk briefly about two projects that perhaps will give you some grounding in how we think about health promotion, well-being, and equity. One is a project that we did with the city of Santa Monica that's ongoing. It's part of a Bloomberg Mayor's Innovation Challenge Award, and really was guided by this idea that I think is embedded in the future thinking of Healthy People 2030, that we have to think intersectorally, we have to think about health promotion and not just primary prevention, and we have to think about how to think about holistic needs of individuals and communities. And so Santa Monica embarked on basically transforming government, trying to embed well-being in policy budgeting, and moving beyond traditional outcomes of health and economics like GDP and local revenue alone. Well-being measurement at the time had fallen a little bit short. It's very influential in terms of trying to track measures of subjective experience, but it had not yet really embedded in the practice of government and the science of well-being. There hadn't been coordination around a common well-being agenda, and it hadn't been linked to budgeting and resource allocation at a community or civic level. And this is really where well-being policy and practice is now going, both in the US, but really internationally as well. And so we developed over many parts of interaction with experts, with local stakeholders, with the literature, with research, a framework that would guide civic well-being in Santa Monica. And I just briefly lay it out here. The top is essentially the 6 dimensions of the framework. Each dimension has subdimensions. And the idea of the framework was that local adaptation will always happen in terms of well-being management, measurement, and monitoring, but that the framework itself, the dimensions and subdimensions, could be transferred to other communities in the U.S., and it has, as we've trained other communities in what we've done in Santa Monica. And then an example of sample measurement. Now, we were really looking at local level information, but we pulled from national data sets as well as local administrative data, and uniquely brought in social data, social platform data, and survey data as well. Some of this, of course, is not possible at a national level for HP 2030, but I just wanted to give you a sense of the kinds of things that we brought together. And so each of those dimensions, essentially, as I said, had subdimensions, just to give you a sense of what we were trying to track. The outlook dimension is kind of the realization that you're investing in health and well-being in a community, that you have change in people's outlooks, but not just in terms of their day-to-day emotions, but their life satisfaction, their evaluative, their sense of meaning, their purpose, their flourishing and thriving. And this is where a lot of the conversation on well-being is going, but is something that can be embedded in national surveys. So just to give you a sense of some of the example items that we had, we looked at things like day-to-day emotions, which we know matters for stress and loneliness, as well as long-term well-being. But we also looked at things like community connection, right? So we looked at dimensions of local networks, community identity, and civic engagement. This is absolutely critical when we think about social isolation, loneliness, mental health issues that we know, diseases of despair that we know are certainly concerning right now in our nation. So examples of this certainly included, how are people relating to their neighbors? Here we brought in national data as benchmark framework, and these are things that could be considered going forward in HP 2030. But we also looked at aspects of civic well-being, which meant that we looked at things like civic participation and civic engagement. As you think about social determinants of health and structural and systemic issues, not just clinical social factors, thinking about civic participation, civic engagement, aspects of governance and political participation, we felt had to be part of the conversation as well. Of course, we also wanted to look at the built and natural and social environment, so we had a dimension called place and planet, as described here. I won't go into detail on each of these, just to give you a sense of things. We know lifelong learning matters for health and well-being across the lifespan and for thriving and flourishing. And that doesn't just mean educational attainment, that means access to learning opportunities across the lifespan. So capturing that eventually, hopefully at a national level, is important. Certainly, we have our more traditional measures of health, but including physical, mental, spiritual, and emotional health and well-being, as well as access to resources. At the local level, we were able to really use GIS and social data to map availability of those objective well-being amenities and contrast that with subjective experience. And so we were able to kind of pull this all together. And then finally, we looked at issues of economic opportunity. And here we're looking at everything from affordability, housing affordability, which I know is in the mix right now for HP 2030, but also issues around access and opportunity, availability in terms of labor market, business diversity, which of course is important at the local, state, and national level as well. So taken together, all of this has informed, and there's more detail on the dimensions and subdimensions, but the point was that we thought a lot about what a community could invest in from the outset and designed the selection of dimensions and subdimensions to think about what were the levers of policy and practical change. Now this index is being used locally in Santa Monica to inform budgeting. So all of the city agencies, not just, and in fact, Santa Monica does not have a health department, but all the city agencies own the well-being index and own all dimensions of the index so that they can tie it to performance and accountability measures. So let me just talk briefly about building a culture of health, which is the effort from the Robert Wood Johnson Foundation, which many of you may be familiar with. This really took an approach of kind of the fifth wave of public health, meaning the post-social determinants of health, with the idea being that if we're trying to actually move and accelerate population health, well-being, and equity, we have to continue to invest in healthy communities, and we have to continue to invest in integrated health services and systems, which is action area 3 and 4. But we absolutely have to think differently about intersectoral collaboration and not just public health and health departments and healthcare partnering with those outside of traditional health, but those agencies and those entities owning health and well-being as part of their mission, as a primary, not as a secondary. And also to think about cultural and social underpinnings, that is the action area, making health a shared value. How do we value, and how do we value in a non-monetary and a monetary way, health and well-being? All of that is part of the culture of health action framework. So one of the things that's kind of useful to understand about the culture of health action framework is that it was really driven behind this idea of catalytic action, not a performance measurement or monitoring system. So that the design of the action areas, the 3 drivers within each of the action areas, and the selection of illustrative measures really represent places and signals that we want to go. Not in the sense, the exact sense of leading health indicators, but I would venture to say signal change elements that if we're to really accelerate change as a nation in health outcomes, health, equity, and well-being outcomes, we needed to indicate and signal to other sectors that they're part of the opportunity and the challenge going forward. So each of the action areas also includes not just classic performance or mortality, morbidity, disease outcomes, but really indicators and measures that relate to systems and history, that relate to policies and governance, that relate to other sectors engaging in health and well-being. So for example, in Action Area 2, fostering cross-sector collaboration that, to improve well-being, we have a measure whereby we've coded all of the executive agencies in the federal government outside of HHS and their investment in health. How do we understand resource allocation going forward on those upstream drivers, those social and structural drivers of health? We look a lot at things like mindset and expectation and sense of community. We know that in order for a community to be healthy, and in order for a community to want to invest in health and well-being, they have to have the ingredients in terms of prioritization and willingness to invest in health and well-being. So these are new measures, new insights that haven't been perhaps tracked before, but we believe are really absolutely critical for accelerated health progress as a nation. Of course, there are still elements of this framework and the drivers and the illustrative measures that will feel familiar in terms of the built environment, as well as improving the balance and integration of health, public health, and social services. Ultimately, we're working towards improved population health, well-being, and equity. So we're looking at improvements in outcomes of well-being, like life satisfaction, work-life balance, and the like. We're, of course, looking at reduced healthcare costs and preventable hospitalizations, but we're also elevating our interest in things that we know are indicators of an unhealthy nation. For example, one of the illustrative measures is incarceration. The idea being that it's not only a structural determinant and driver of health, but in and of itself is an indicator of an unhealthy nation. So that's kind of the spirit behind the Culture of Health Action Framework and the drivers. In terms of how we selected our measures, and everything is available on the websites here, just given time, we were looking at national data, which is not easy, so I don't envy this group. Unlike the Santa Monica effort where we could benefit from local data, we were looking at national data. But we actually pulled in a lot of national organizations in addition to what we pulled from the American Community Survey or NCHS or other federal agencies that provide information on health and well-being. We had an orientation to lifespan as well as health span. We wanted to make sure that we reflected the fact that health and well-being is not about perfect health, but about how people are managing the ups and downs in their health across the life course trajectory. When we thought about upstream drivers, we did think not simply about what I call clinical social factors, but rather long-standing social determinants, so things like residential segregation, air quality, climate action plans, and the like that we know have many related sectors that are involved, so it appeals to multiple audiences, but also are absolutely critical for long-standing chronic health issues as well. One of the things that's quite critical about what we did is that we looked at signals that would consider equity, not closing gaps in terms of disparities. So we're really thinking about things that signal access to opportunities, fair and just access to opportunities, and that we could tell a story with through the action framework, through the drivers, and through the illustrative measures. So that was absolutely critical as well. We have a lot of this published in various forms. I think some of this is in your resource guide, but I wanted to mention an article, very short article that we wrote in Stanford Social Innovation Review, which talks about our approach to selection of catalytic measures rather than performance measurement. And it may be useful for anybody who's interested, it's short, as I said, to understand a little bit of our approach and the way that we tried to signal other sectors to engage in health and well-being as well. Finally, as I was taking a look at the work that's already happened, which is tremendous, I thought there were three buckets that were missing from my perspective based on what I know working locally as well as working on culture of health. One is the measures of subjective well-being. We say a lot in the well-being field, it's not just about the hedonic, the day-to-day, am I happy or not, but it's about life appraisal and meaning and purpose. Some of my colleagues are quick to point out that if we had been tracking many of the evaluative and eudaimonic measures of well-being, we would have anticipated many of the challenges that we now face in terms of diseases of despair. How much are we really measuring structural and systemic drivers of health and not just usual social determinants of health or social clinical filters on health? And then finally, can we capture something about the civic environment or the community environment? I know that's difficult at a national level, but can we at least capture some signals of environments and policies that support not just disease prevention, but really the aspects of thriving and flourishing? That means hope. That means autonomy, that means resilience, that means many of the policies that support conditions for thriving and flourishing over the lifespan. Thanks.